You will not Okay, good morning everyone. My name is Shannon Gunawardana and I'm a fourth year medical student, and this year I'm the student lead on Project Oxplore. Oxplore was founded last year by Roshni Mansfield, the previous president of Oxford Society of Paediatrics, with the help of the Paediatric Surgery Department, and in particular Prof Lakhoo and Kat Ford. Oxplore stands for Oxford Paediatrics, linking oncology research with electives. The idea of the project was to involve Oxford medical students going abroad for their placements or electives, because we thought while students were abroad, it's a great opportunity for them to get involved with research as they have free time and also access to data and patient records that they can't necessarily access here from the UK. We also wanted to create sustainable links with junior doctors and medical students all over the world. The idea would be students undertaking research from Oxford would travel abroad and find a contact on the ground that could continue the research and data collection upon their return back here to the UK, so that this project and data collection would be sustainable. So first, some background about surgery, global surgery and global paediatric surgery in particular. There is a gross disparity in surgical care worldwide and an urgent need in the world's poorest regions. This has been reported on for decades, and diseases treated by surgery are still amongst the top killers in the world's poor and underdeveloped countries. Pediatric surgery in particular was once coined the neglected stepchild of global health by Jim Kim, who went on to become the first clinician president of the World Bank. So what are the reasons for this disparity? There are numerous reasons. Firstly, for a long time, a lot of the world's attention and funds has been focused on treating communicable diseases. As resources are limited, little attention was then spent on surgery. Secondly, surgery is a highly complex intervention, which not only requires a surgeon be present, but also an anaesthetist, cross-match blood, sutures, drapes, and far more factors. There's no surgical equivalent to creating a vaccine campaign or sponsoring a mosquito net. To do surgery properly, we require significant investment in infrastructure, training, and a ready supply of consumables. Finally, there's been a challenge to really measure the burden of surgery, because diseases treated by surgery have a varied etiology, and for a long time the focus has been on diseases rather than their treatment. And now to talk a little bit about global paediatric cancer, which is the current focus of Oxplore. So global paediatric cancer actually represents a very small proportion of the global cancer burden. However, a large proportion of these childhood cancers occur in low and middle income countries, and this is because there is a disproportionate number of the world's children in these places. Unfortunately, although this is where paediatric cancer is most prevalent, according to the literature and our preliminary data, it seems that outcomes for these children are far worse than those treated here in the UK. So what are the top cancers affecting these children? So in the under 4 age group, retinoblastomas, neuroblastomas, and Wilms are highly prevalent. In slightly older children, sarcomas are common, and across the age groups, in paediatric tumours, hematological and brain tumours feature widely. So what was the proposal of our project? We wanted to answer the question, how does the global experience of treating paediatric solid renal tumours vary between the UK and lower and middle income countries? We decided to focus specifically on 3 types of paediatric solid renal tumours: Wilms, neuroblastomas, and rhabdomyosarcomas. Our primary outcome was looking at survival. We wanted to see how mortality rates vary between institutes. Our secondary outcomes were numerous and included access to pre-op chemo and radiotherapy, where this treatment took place, incidence of cancer, post-op nutrition, and palliative treatment as well, where applicable. So what was our proposal for the project? We really wanted this to be a student-led initiative. We wanted our medical students to understand what it would be like to go abroad and try and set out partaking in research collection, and also to understand the hurdles that they'd face and how to overcome this. From my work with it during this year, I've already learned how difficult it is to communicate by email with people abroad when you don't necessarily see them, and how things take a lot longer when you're doing it internationally. We wanted this to be a retrospective study, and we'd validate our data by cross-checking 10% of it. Ethics was done here in Oxford individually, and then across our institutes, it needed to be done at an institute level for each institute taking part. So what were the benefits for the collaborators in the countries abroad who'd be involved in this project? Well, here at Oxford, our medical students are very lucky as we have access to very high quality research and the opportunity to get involved in many projects. Unfortunately, this isn't the same for medical students all over the world. So a big appeal of this project would be that any medical student or junior doctor abroad taking part in this project would be an author on anything we produce or publish. Importantly, we also wanted this to translate to patient care. So we want to identify where resources are most needed, and we wanted Oxplore to add as an advocacy tool for obtaining these resources. So what's our plan going forward? Firstly, we need to identify interested elective students going away on their placements or electives. Last month, the Oxford Society of Paediatrics had a launch event for this project, where we tried to get as many students involved as possible. Going forward again, we'll need these students going abroad to go about finding the ethics in their locations. And finally, as a long-term aim, we want to look into funding to expand this project further. So what do we require from students taking part in this project? Students are responsible for contacting institutes ahead of time and liaising with them to see whether they'd be interested in getting involved with Oxplore. Oxplore has created a general letter that students can send out to their relevant institutes, sort of detailing what Oxplore is and that we have the backing of the Paediatric Surgery Department here. Ethics. This is currently the rate-limiting factor we've discovered in phase 1 of the study last year. Ethics seems to take a long time to get approval for, not least because it varies from country to country, and even within countries, it varies from institute to institute. So we really encourage students to get this set up before they go abroad, so that as soon as they arrive in the country, they can really get involved with data collection. As you can see here, this is the pro forma we created for data collection. It has a few different categories, the first being patient demographics and the type of tumour they presented with. The second sort of being their pre-op status, any chemo, any radiotherapy. And then we talk a little bit about the surgery they have. And finally, post-op, their nutritional status, whether palliative care was needed when necessary, and also surgical outcomes. This data pro forma is a fluid process, however, as I'll come on to talk to. So phase 1 of the study really happened last year, where we set up 2 successful institutes in Rwanda and Tanzania. The Rwanda Institute was set up by a 50th medical student, Hugh Hathaway, who went and met Emery, who is photographed here, who's the junior doctor really running this project on the ground now as we speak. We also have a centre in Tanzania, which is being run by Godfrey Sama. He's in the top corner there. And the phase 1 study was looking specifically at Wilms tumours. Going forward, we'd really like to include neuroblastomas and rhabdomyosarcomas, as we have already collected the data for these 3 tumours here in Oxford from the last 3 years. The data pro forma was a fluid process because Emery thought it was really important actually to look at the social status of parents of the children who presented. So he modified the pro forma slightly and added a social class box that we don't have in the Tanzania cohort. So what has been the output of Oxplore so far? So last year's Oxplore team successfully presented the poster of concept for Oxplore at the RCPCH conference and the UCAPS conference, for which it was awarded a prize. Last year's team also created a letter and published in PSI for the concept of this idea. Finally, Oxplore is a great opportunity for 4th year and 6th year medical students doing their SSMs to get involved with paediatric surgery. Zara, 4th year medical student, recently did a systematic review of Wilms for her SSM, and this is hopefully looking into publication. So what is phase 2 of our study? We're hoping to keep expanding, so any medical students here who are interested, please drop me an email at the end. In the short term, we're aiming to present at PAPSA, the Pan-African Paediatric Surgery Association in Addis Ababa in November. So hopefully the Rwanda and Tanzania data will be in by the end of the summer so that we can compare it to our Oxford data and present. Going forward, we want to build on our database from medical students in different institutes, analyse our data, explore the results, and hopefully publish. Thank you for watching, and any medical students who are interested, please drop me a message. Thank you.
Okay, thank you very much for the opportunity to present this morning. So moving on to now to a bit more in depth about how as a trainee, if you're interested in global surgery, different avenues through which you can be involved. So I'm going to do a couple of slides on dispelling any myths people may have on global surgery, focus on paediatric surgery, in particular congenital anomalies, and then give some examples of some projects I've been involved with over the time that I've been interested in global surgery. So the first myth that unfortunately many people still have is that global surgery is very expensive and it's not worth funding. We know that's categorically not true. When you look at the cost of averting disability-adjusted life years, the cost of surgery as an intervention is akin to oral rehydration therapy, both of which are far cheaper than more often funded projects, such as things like antiretroviral therapy. The second is that surgery is too difficult to perform. We don't even have to address this morning. There's been lots of evidence, both in sort of high-impact journal publications and also publications from humanitarian organisations, showing that surgery is feasible as an intervention and it can have good outcomes. We won't dwell too much on the Lancet Commission of Global Surgeries, only to say that if you haven't read it, it's a fantastic document and really sets the scene for global surgery in modern-day global health. And its main key point, which is one of the things we want everyone to take away from today, is that 5 billion people in the world lack access to safe surgical and anaesthetic care. So looking at children specifically, if we look at mortality in under fives, we can see that congenital anomalies constitute a high proportion of death in this age group. But it's not only death that congenital anomalies cause. A lot of children have a simple, relatively simple congenital anomaly that they live with, but it has a huge impact on their life and their morbidity. Not only does it affect the child, it affects their family, and it can be a catastrophic event in that family and lead to impoverishment and catastrophic health expenditure. But how do we advocate for these children? Well, one way that we, as sort of academic global surgeons, are trying to advocate is using the global burden of disease as our currency. So when we look at congenital anomalies, we know that they constitute 2.1% of the world's total disease burden. They've ranked 11th in the causes of disease burden published by the WHO. But still, there's only a small body of literature describing the impact of surgery on these conditions. So the UN Development Goals are a bit outdated now, but we know that their goal number 4 was to reduce childhood mortality by 2/3 in that 15-year period. And great success was had in this field, but still, there's still work to be done. So the second line down, this light blue line, shows neonatal mortality over that 15-year period. So we can see that it's dramatically decreased, but it's still far higher than many communicable diseases. So we've got HIV/AIDS, TB and malaria that constitute less deaths than neonatal mortality, which is still a new concept for many people. So looking at neonates in a bit more detail now, I was involved in a project where we evaluated the outcomes of neonates in a neonatal transport service in central Lagos. The aim of the project was to essentially audit their service over a 3-year period. So we looked at just under 1,000 neonates being transported, just over a third of which were preterm. A majority were travelling in the specific ambulance associated with the neonatal group. However, just over 10% were being transported in private methods, mostly motorbikes. So the primary diagnosis of the infants has been categorised. Majority had sepsis, GIT, haematological conditions, or cardiorespiratory problems. And the overall mortality rate for this cohort of patients is 41%. The infants are more likely to die if they would, obviously if they were travelling in the private means of transport or if they're preterm. And we showed that the highest cause of mortality was due to sepsis or cardiorespiratory problems. There's been no other or very limited data in this field from sub-Saharan Africa, but when we compared to other middle and high-income countries, clearly this 41% mortality is far, far higher than other places. A couple of examples of collaborative research. I did a 6-month global surgery fellowship in King's College in London, and my supervisor at the time was receiving correspondence from another trainee doing an UPI who'd noticed that the mortality from infants with gastroschisis was incredibly high and was a huge comparison to that in high-income countries such as the UK, where the survival of these infants is essentially 100%, 95 to 100%. So we formed Gastroschisis International in 2015, which is a sort of collaborative research group, sourced funding from the RSM and BAPS, and one of the outputs from this project was to suggest that gastroschisis is a bellwether procedure for neonatal surgical conditions. And the bellwether was sort of coined by the Lancet Commission, and it essentially is a proxy, so it's a condition or an intervention that acts as a proxy for similar conditions. So if you said that the survival of gastroschisis is X in one institution, you would expect that survival of other similar neonatal conditions would be similar. We also did teaching interventions with models in various places, and we're trying to advocate the use of preformed silos in these infants. The core research team is multidisciplinary, involved neonatal nurses and nutritionists, and we had collaborators from 5 sub-Saharan African institutions. We used the global burden of disease metrics and showed that the averted burden of disease is higher in centres where the survival is higher. We also compared that averted burden of disease to other common paediatric surgery procedures, such as paediatric herniotomy. And as you'd expect, the averted burden of disease is far higher when you get infants to survive from gastroschisis versus that from a simple herniotomy. We were invited to write up our experience in The Lancet, which is very important as it widened our readership and hopefully is helping with advocacy. A further example of collaborative project was one involving PAPSA, which Shannon briefly mentioned. So it's the Pan-African Association of Paediatric Surgery, where we conducted an investigation to 30-day hospital mortality after admission under paediatric surgery. We had 8 participating centres from different high and low middle income settings, reporting 1,000 children from both the high and low and middle income settings. The overall mortality from this cohort was 1.2%, and there's a huge disparity in where those children were from. In terms of diagnosis, as we alluded to earlier, we found that a higher proportion of the diagnosis were related to a congenital anomaly, and we saw the sort of usual spread of paediatric surgery anomalies in the cohort. The deaths attributable to diseases of childhood were primarily typhoid perforation and also interception. In terms of patient pathway, the median time to death of this cohort was 8 days, and 80% of those that died had some form of surgical anaesthetic procedure. And the median time to surgery for these patients was 2.5 days. The cause of death was varied, but mostly attributable to sepsis, which clearly is relatively easy to intervene and to help improve. In terms of outreach, the trainees can have sort of 2 options. You can either do a prolonged period of time in a different setting or a short visit to a lower middle income setting. And my involvement primarily has been as short visits through WACS, which is the West African College of Surgeons, which is actually a very successful institution formed in the 60s, and it really reflected the democratic change in Africa at that time. They have an annual conference, and the week preceding the conference, there's an outreach mission. This year in February, the mission was in Gambia, which is a West African country sandwiched between Senegal on 3 sides and the North Atlantic coast on the west. It's a very small country with a population of 2 million, 50% of which are children. Being a small country, it's got a very poor healthcare system with no higher surgical training and no paediatric surgeons available to manage any surgical pathology in that population. So the trip centred around the gentleman circled here, Cherno Jallo, who's a local trainee who's got an interest in paediatric surgery, who is training in Ghana and is trying to improve paediatric surgery in his country. So he was the pivotal point which made the trip so successful. In the weeks and months preceding the trip, there's a high level of organisation. We used sort of low-tech innovation like WhatsApp to share ideas and photographs of equipment, and treated a range of conditions from cystic hygroma, esophageal atresia. We saw the very late presentation of things like Wilms tumours and colorectal problems. This baby's got a sternal cleft. We didn't operate on this baby, but were able to facilitate the child being transferred to Senegal for his further treatment. We also had to think on our feet and do a lot of lateral thinking. So late at night, we were doing a resection of posterior urethral valves, and the only bulb on the stack that was available in the hospital blew. So we used, sort of working together as a group, we thought about using the light of an iPhone and was able to illuminate the optic cable, and it worked just as well as a stack, much to our surprise. So Cherno is leading the drive now to change or to build a partnership between King's and Gambia. The long-term goal is to develop a national surgical plan for paediatric surgery in the Gambia. This is clearly a stepwise process, and it has to be led by him, and we, as a sort of high-income institution, can support and offer guidance where needed. So we're working on a 10-year plan, and one of our group is going out to spend eight weeks gathering granular data for this partnership. Another partnership, which I'm sure many of you are familiar with, is Prof. Lakhoo's long-standing partnership with Tanzania, which I was fortunate to accompany her on a trip in November last year. And the thing I wanted to mention about this is the hospital have recently got 2 new paediatric theatres kitted out through the Archie Foundation, which has had a huge impact on the paediatric surgery department's thoroughfare of patients and their outcomes. So that was amazing to see that the impact that's been having. And finally, trainees can be involved in teaching and training. So back in 2013, I went to Ghana and was involved as a kind of assistant faculty in doing the basic surgical skills course in a multidisciplinary setting. So we were also teaching nurses and scrub nurses about basic surgical skills and anaesthetists as well. At the recent PAPSA course in Lagos, BAPS ran a neonatal course and a laparoscopy course, and we were able to trial this low-fidelity appendix model, which one of my colleagues here, Natalie and I, and a colleague in King's, developed when we were doing our ST3 interviews many years ago as a practice for our interview. And we thought that it was so easy to do that it could be used in the low and middle income setting, and we validated it for laparoscopic training in that setting, and it's had very good reports. And the other benefit of it is that each unit costs 45p to make. So we're trying to write this up to show that it's an innovative idea for the middle-income setting. And just a quick word about global surgery groups, if people want to be involved. There are different institutions in the UK that have really fantastic global surgery groups and clinical consultants who can support trainees. So Oxford clearly is one of them. King's and Birmingham Leeds also have big centres. And the colleges in Scotland and Ireland are also very productive. And there's also GASOC, which is a UK-wide trainee group, which we founded in 2015, actually at the launch of the Lancet Commission. You can read about our objectives and things on our website. We've got various patrons, collaborators. We run courses and conferences frequently and have a 2-monthly journal club and research meeting as a kind of Skype tripod between Oxford, King's and the Royal College of Surgeons and Physicians in Glasgow. We try to have a voice, and we respond to global surgery articles. We've written a paper on the role of trainees in global surgery. And our final goal is to try and develop a career pathway that's less ad hoc than my peers and our seniors have had in the past. So our idea was to have a sort of global surgery training system that's a bit like an academic pathway, so that you have time to do your research and to spend time in the low middle income setting. Thank you very much.
What I'm going to be doing is just talking about what's happening around the globe regarding children's surgery. So as you heard from previous speakers, that 2015 was the year of the global surgery, where an interested group of people related to surgery tickle the appetites of donors, policymakers, international organizations, that surgery is also a global disease and needs attention. And the way they did it is by numbers. You heard that 5 billion people don't have access to surgery, and they're all from low and middle income countries. How many surgeries will be needed in low and middle income countries? And all figures in terms of finance does make sense. But what really tickled the appetite is that $21 trillion loss of global productivity will take place up to the year of 2030 without any input into global surgery. So the Lancet Commission in its preparation didn't translate to children. And there was very sparse input by low and middle income countries. Despite about 50 to 60% of the population in low and middle income countries being children, and 85% of children in these areas will require a surgical procedure, be it a dental extraction. So a few of us approached the Lancet Commission and said, look, what about children? And the answer is, look, you guys are children's advocates, so just get on with it. So we did. Just 2 of us first started a conversation, and then 4 of us started preparing that we need to have a children's group so that they are not ignored, as we've heard from previous speakers. We also used finance, and this was our punchline, that surgery is not expensive. Our aim was to identify solutions to problems, and we were going to use the expertise and experience of practitioners from around the world. We were choosing people that we knew that were workhorses rather than those in suits walking from one meeting to the other, because we know we wouldn't achieve anything. The scope we used was children's surgical carers, because it's pointless working with surgeons and no anaesthetists. And time and again, we hear this in this institution as well, that, oh, we cannot operate on this child because the anaesthetists are not comfortable with it when we have DGH referrals. So it's the same principle. So we've included all these groups so that it would be more cohesive. Our task was to invite LMIC representative, fully sponsored, set the scene, and identify solutions. Most of the funding was soft funding, and some of us did long-term locums to support this. We set a timetable, starting with a teleconference every 2 weeks, just 8 people within the steering group, of which 60% were from LMIC and 40% from HICs. And because of global time schemes, I had the short straw of 4 in the morning every 2 weeks from August 2015 up to date. In between telecommunication, we realized that we needed face-to-face meetings. So we had the first meeting in London with 50 attendees, trying to keep this ratio so that we could start an analysis process. And we had a second meeting having a planning process, again, making sure that we don't get inundated with high-income country representatives. And it's always very difficult in America to do so. We then had our third phase, which was the implementation phase in Vellore in India this year, choosing a low to middle income country, and that was the representation. So what is the output? I was not going to describe all the activities that took place, but just show you where we are. So we started off with setting standards, and the low and middle income country colleagues of ours said that we need a document that sets standards, that has human resources, that has physical resources, research guidelines, and can be adaptable to local setting. And this document has everything from all surgical specialties, anaesthetists, nurses, whoever want to use this as a resource setting. We have now WHO approval of this document, and it will be official on the 1st of July. What is this document intended for? It helps healthcare deliverers to set a standard. It helps organizers to bid for resources from their hospitals. It helps educators to validify their training modules. It helps policymakers to have national surgical plans, and it also helps with fundraising. What we did is we used the World Bank strategy, because each country has a different way, or each region has a different way of stratifying their hospital system. So we chose to use the World Bank one, and we added National Children's Hospital. What the document contains is just basic definitions of what basic surgery is, intermediate surgery, advanced surgery, just a flavor of what it has. If you look at the training area, it has just recognizes what community and primary healthcare centers training is all about, or a guideline of what it should be. And then if you look at the research aspect, again, what kind of research could be feasible from different healthcare levels. Looking at the next project regarding manpower, as you know, and you heard from Kat's talk, that there's a dearth of gaps in pediatric surgeons around the world, or pediatric surgical teams around the world. So we formed a collaboration between Vellore India as a training institution and the Royal College of Surgeons who will validify the project. We decided that it's pointless having high-income country groups going to do training in low to middle-income countries. It needs to be an LMIC to LMIC training because it would be more relevant in terms of resources and disease process. Our target was the third delay that has been identified, and the project involves a tertiary level hospital, which is Vellore, which has identified 5 district general hospitals and get the teams around to be trained in children's surgery. So the teams would include a general surgeon, orthopedic surgeon, anaesthetist, a ward nurse, and theatre nurse. That is Vellore, which is the hub. These are the 5 hospitals that they've identified. And this is quite a political hotspot because this country is part of India but separated from India by Bangladesh. The 3-day program regarding this involves lectures, scenarios, teamwork, simulations. It involves training the trainer for Vellore and DGH individuals, and we have a generic and a specific program. In our first pilot, we showed a 44% improvement, and the outcomes in the first 5 months showed that there were 120 calls via WhatsApp, there was 30% reduction in referrals, 90% appropriate referrals, 70% well-resuscitated patients were transferred, 20% were remote procedures such as suprapubic catheters were done through a Skype call and processed because the patient couldn't be transferred. And 80% of remote radiology and pathology is being provided. Next weekend, together with Jim, we're traveling to do the second pilot with the aim of then rolling it out to other parts of the world. And at that point, we will get the instruction manual ready. GIGS has formed training hubs. And as I talked about south-to-south training, it's pointless having trainees come to the West to have their training, which is quite inappropriate. So these are the selected hubs in different countries, this being in Papua New Guinea and Brazil and Peru in South America. We don't have a training hub as yet in Central America. We also have embraced this book. So in 2012, a group of pediatric surgeons from high and low-income countries produced a textbook relevant to African diseases. And it was very popular. It had the highest hits for downloading 3 chapters from this book. It was translated into 5 languages. So GIGS has now taken on the project, and we hope to get the second edition done in 2018. The beauty of this book is that every chapter is written by 2 authors, one from high-income and one from low-income countries. We also have a platform where trainees who wish to do research can use GIGS as a platform for getting collaboration, for identifying good collaborators. And it's the first time in pediatric surgery that we have a global PhD and an MSc in process. We've also formed research hubs. Some are still in the making, but the one in South Africa has been established, but we're waiting for more funding to make it more productive to help the countries in Southern Africa. Kat spoke about the donors, so we have attracted donors within GIGS as well. So there's a Scottish family, the Wood family, who had a very tragic experience of losing their premature twins with necrotizing enterocolitis. And they felt that with their wealth, they'd like to use it to make an impact, especially in countries where children's surgical need is there. So they've been proactive with us, and we serve as a guidance for them as to which country there is pediatric surgeons but don't have theatre facilities. So they've put in 2 theatres in Uganda, Tanzania, 1 in Malawi, and as I speak, 1 theatre is being put in Rwanda. They're going to spread out of Africa to the next project being in Nicaragua and then Bangladesh. But just in Tanzania, where I have more information about, that they had a 3-year waiting list because they need to share theatres with adults. And this is the bind of pediatric surgeons all over the world, even in this institution. When we have to share theatres with adults, we always get sidelines. And I hope there are some neurosurgeons here. So in Tanzania, to try and do this, they have 2 half days a week, and they would use 2 operating theatres within that room to try and get to the waiting list. And if there's a cesarean section, all the theatres just get given up for cesarean section. So to avoid the competing, the 2 new theatres that were put in September of last year, the team with their administration worked from 8 in the morning to 8 in the evening to clear the waiting list, which they did. And when I arrived in November for my yearly project, there was no waiting list, and we were busy doing other training issues and new patients without needing to scramble for theatres. Nicaragua has also asked us to run a project with them, and this project is mainly aimed at primary healthcare workers. The project was designed by Smile Train, who's fully funded the project, but they wanted gigs to validate the project. So 2 of our colleagues and the 3 of us are routinely in touch and are making site visits. So Nicaragua is part of Central America, and they use one of the cities, and to validate that, we've used 4 validating tools, and this has been the results. And I just wanted to show this picture to show the commitment of the health workers, that even a baby and not having access by foot does not stop them doing their healthcare projects. We have, from January, we have a liaison with UNICEF in India, who produced a very successful chart on congenital abnormalities. Now, India had a good vaccination program by using ASHAs. Now, ASHAs are healthcare workers that went door to door and vaccinated children for polio. So we're using that same army of individuals for them to identify congenital abnormalities so that they can be reported and managed earlier. I've spoken mainly about pediatric surgical activities, but the neurosurgeons in our group are also very active. They formed an intersurgeon website where neurosurgeons or pediatric surgeons or adult surgeons, if they have any difficulty in a child with a neurosurgical problems, they can get onto this website and get assistance through electronic medium, or form partnerships, or form collaborators. And my colleague from Great Ormond, a retired colleague from Great Ormond Street, William Harkness, calls it a dating platform. And then colleagues of mine in Uganda, there's a husband and wife team from a high-income country who are living in Uganda and have become Ugandan citizens. And the husband is a pediatrician and the wife is a pediatric surgeon. And they formed a mobile clinic where they go out into the rural areas to help with and train in pediatric surgery. This project was presented at the India meeting, and we're running a pilot in Papua New Guinea. So different parts of the world are now wanting to use that project. Similarly, the anaesthetists have formed a group. The radiologists are training radiographers so they can do virtual reporting. Pathologists are training technicians to prepare slides in LMICs so that they can be relayed for pathologists to be able to read them where there are pathologists available. So as of 1st of July, the global initiative, which was just a loose body, is forming an organization. We chose America to register this as a non-profit organization because you get 50% gift aid in America rather than 20% here. We formed 20 members of directors, I'm going to lead on this for the first 2 years, and then we have a president-elect from low-income countries. We have working groups and we have committees. To join the organization, if you are dealing with children with surgery from the LMIC, you need no conditions. If you are from the high-income countries, you need to bring 2 low-middle-income country partners with you so that the organization remains low-income country dominant. That's our website, so there's lots of information on there. And I thought I'd like to end with a story, and stories are always something that strikes a chord with people. This is a story about an 8-month-old baby who had blood in the stool. Baby was one of 6 children. They took the baby because they come from a remote area. The first port of call for medical attention is traditional healers. The traditional healer gave a soap enema and made marks on the abdomen to say that the evil will be removed from this baby's belly. The baby's condition worsened, so the mother absconded from the village and tried to reach medical care by walking 25 kilometers. She reaches the primary healthcare facility, but the baby is too ill to be managed there, and an ambulance is a day away. So she uses all her savings to take a taxi 70 kilometers away to get to a tertiary center where this baby could be managed. In the meantime, the older 2 siblings stopped going to school to work on the farm, and the other one to find a job to sustain the family. The child is dead on arrival at the tertiary center because it's too late. I happened to be in the institution when this child arrived. The mother then took her life 2 days later because for her to return to her village would be a nightmare because she absconded and the baby is dead now. Let's just hope that such occurrences are things of the past and we don't have to deal with them again. Thank you.